Well, hello and welcome to Alterations in Cardiovascular Function. This is Module 6, and what we're going to be discussing here is we're going to be talking about, first of all, the normal cardiac function and some of the review of anatomy and physiology, but then we'll also be moving on into our abnormal cardiovascular function and some of the problems that we may see in our patients as a result of that abnormal cardiovascular physiology. So first of all, let's go back and let's just review a little bit of some of the normal anatomy. So here is a picture of the heart over on the right-hand side, and you can see that it's usually contained within the mediastinal space. The mediastinal space is the space in the middle of the chest wall. So we have the two lungs, one on each side, then we have this space in the middle. Now the mediastinal space is actually a separate space, so it has its own fascia that covers it and so on and so forth. But remember that all of that is contained within the thorax. So any changes that are occurring in the lungs, if the lungs become overinflated or underinflated, etc., that's going to affect the mediastinal space, and it's going to affect the cardiac function. The heart is covered by the pericardium. The pericardium is the outermost covering of the heart. The pericardium is going to be the covering of the heart that holds it in place. So it not only covers the outside of the heart and kind of protects the outside of the heart, but it also holds the heart in place. So it's anchored inside the chest wall, and that's going to keep the heart from bouncing around and moving around inside the chest. Otherwise, if we didn't have a pericardium, the heart would just kind of bounce around inside that mediastinum. That's not a good thing. Now, it's composed of three different layers. We have the epicardium, which is part of the endocardium, and we also have the myocardium as the muscular layer of the heart. So we have the pericardium on the outside. Let's move on in. Next layer would be the myocardium. The myocardium is the muscular layer. See the myo part? So the myocardium is the muscular layer of the heart, and that's the part we're mostly concerned about when we're talking about patients who have myocardial infarctions, is we're worried about having some dysfunction, some damage to that myocardium. The epicardium, part of the endocardium here, is going to be the innermost layer of the heart, and the thing that's important about that is that this inner layer is going to be coming in contact with the blood. Also, that inner layer is the part where we're going to attach some of our structures like the valves inside the heart. So very important, because if a patient gets endocarditis, that can lead to valvular dysfunction, and that can lead to the patient developing some types of foreign bodies that can be breaking off and moving throughout the bloodstream. So again, here is a picture of where the heart would be located inside the chest. Notice it's a little bit more to the left than it is to the right. So we're not directly underneath the sternum. We're a little bit over to the left more than we are to the right. Take a look at where the ventricle is now in the bottom picture on the left, and it gives you an idea where the ventricle is between the sternum and the spinal column, right above the diaphragm there. So we have the diaphragm coming right up and touching on the lower part of the heart. Okay, now some of these things are significant because if we have disorders in our patients, so again, go up to the uppermost picture, and you're looking at the heart there, and you see how close proximity those lungs are. In fact, the lungs are really touching on either side of that heart. So if those lungs become overinflated, it's going to squeeze the heart. Now look at the bottom left picture, and you see that the diaphragm is touching the ventricle. Well, what happens if your patient has got some kind of abdominal pathology going on, pushing up on that diaphragm? That's also going to impact the ventricle. And then you can see that over on the right-hand side, it's breaking down our inside layers, or it's breaking down our layers of the heart into their different areas. So the pericardium on the outside, the epicardium, then the myocardium, and then the innermost layer, the endocardium. Just as a review here of the vessels of the heart. Now, you're not going to have to know all the detail about all the different vessels of the heart. So if you're looking at this and getting a little overwhelmed, thinking, oh my gosh, how am I going to remember all these? You're not going to have to remember all of them. But you do want to get a feel for where these vessels are coming from and what they're doing. So we have our superior vena cava and the inferior vena cava. The inferior vena cava is on the left-hand side at the bottom. So those are coming together and going into the right side of the heart, specifically into the right atria. From the right atria, then, blood is going to be pumped to the right ventricle. and then it's going to be pumped out through the pulmonary arteries. So you can see it's kind of, they've shaded them kind of purplish here in the picture, the right pulmonary arteries and the left pulmonary arteries. And it goes to the lungs, then it comes back, and it goes through the pulmonary veins. Now those might be a little bit harder to see on your picture there, but if you look right below the pulmonary arteries, you see it's labeled pulmonary veins. So that's coming back from the lungs and coming back to the left side of the heart. So going into the left atria and then getting pumped to the left ventricle and then pumped out through the aorta. Okay, so that's all the circulation that the heart is doing. That's the pumping part and what's happening here with all the plumbing. Now, how is the heart getting fed? Well, the heart is being fed by its own vasculature, and these vessels originate from the base of the aorta. So at the base of the aorta, there are these little vessels that come out and they will feed the heart directly. They're broken down here into the right coronary artery, the left coronary artery. The other one that you often hear about frequently is the circumflex artery, and I don't see the circumflex listed here on this picture, but that's one of the other major coronary arteries that you're going to hear about. So those are just some of the major ones. Notice the right coronary artery is supplying the right side of the heart. That makes sense, right? Left coronary artery supplying the left side of the heart. Okay, that makes sense too. Now, when we look at the coronary vasculature, this gives you a little bit more detail just about the coronary vasculature. We're not getting into so much detail about some of those other vessels, but notice your vessels again. So the right coronary artery, let's go over to the left picture. The left picture showing the arteries and the right picture showing the veins. So the right coronary artery coming down the right side of the heart, and it's going down the right side, around the right side, and actually going down to the bottom of the heart somewhat. So we have not only the right side of the heart being perfused by the right coronary artery, but we also have a little bit of the base, a little bit of the bottom of the heart that is also being perfused by the right coronary artery. This means if there was a blockage in that right coronary artery, the patient would have a right ventricular infarct and or an inferior wall infarct. The inferior wall being the bottom wall, inferior bottom wall of the heart. Now over on the left-hand side, we have a couple major vessels here that are important. We have the left coronary artery, and that's supplying the left side of the heart. So very important vessel, okay, because it's supplying the big pumping chamber of the heart, which is the left side of the heart. We also have the circumflex artery that comes off. Now the circumflex kind of comes off and it kind of wraps around. So it's more of a circular circumflex, so think of circles. So it's coming off and it's going around more than it's going down. So the right coronary artery is going down the right side, left coronary artery is going down the left side, circumflex is kind of going around the middle. So that might be one way to remember it by thinking of a circle. As far as all of these little branches, like the anterior intraventricular artery and things like that, you don't need to get into a lot of detail with those. But look at those branches and just see how the entire ventricle is being perfused by that arterial system. Now, if we move over to the picture on the right, now what we're going to see is here is the heart and the venous system. So now we get the blood there, we got to get it back. So that's what the venous system is for. And the venous system is going to return it. The thing that's going to be the problem in most of our patients is not the venous system, it's the arterial system. And we get a little clot in one of those arteries. It blocks the artery. It blocks the perfusion to that part of the ventricle, and the patient has a myocardial infarction. Autonomic control of the heart, well, some of the major things here is going to be the sympathetic and parasympathetic systems. So this is the central nervous system that's going to stimulate this. The sympathetic nervous system, this is your fight or flight response. Epinephrine, norepinephrine are released. They're going to increase the heart rate and force of contraction. Now, you may have heard terminology before about things like baroreceptors and chemoreceptors in the body. Okay, now we're also going to talk about how those baroreceptors and chemoreceptors can have two different effects on the heart. They can have a effect where they're increasing the heart rate, that's called a chronotropic effect, and they can also have an effect where they're increasing the force of contraction, and that's going to be called an inotropic effect. So going back up to our first one here, norepinephrine It increases the heart rate. That's chronotropic. Think of chrono like a watch or a clock, chronotropic. And then the force of contraction is inotropic. So those are going to be terms that you might see, especially when you get into pharmacology. You might see them using that terminology when they're talking about different kinds of medication. It's a positive chronotropic med, it's a positive inotropic med. It's talking about the increasing the heart rate and increasing the force of contraction. Okay. Let's take a look at the parasympathetic system then. All right. Well, there needs to be a balance. If all we had was sympathetic nervous system, everybody would have a heart rate of 180, and we'd have this huge amount of cardiac output, and we'd wear our hearts out. So there's always this balance between the two. It's kind of like a seesaw. If you have somebody on one end of the seesaw, you have to have somebody on the other end of the seesaw, or it's not going to be balanced. And the same thing happens here with our autonomic controls in the body, is we have to have a balance between the sympathetic, which is the stimulation part, and the parasympathetic, which is kind of the relaxation part. So the parasympathetic system is going to tell the heart to slow down. Okay, now let's just stop here for a minute and take a look at those two things and think about what happens if they get altered. So let's say there's too much sympathetic nervous system stimulation. That means the patient would have an increase in their heart rate, they'd have tachycardia, and they'd have an increase in force of contraction, which means they would have an increase in their cardiac output. We're going to talk more about that in other classes, about what an increase in cardiac output might look like. How about the other side of the coin? Maybe the patient has too much stimulation of the parasympathetic system. Well, the parasympathetic system is going to decrease the heart rate, which means your patient could develop bradycardia. Maybe their heart rate's down to like 40 because they've had the stimulation of the parasympathetic system. So those things are constantly in balance. If it's out of balance, it's going to lead to an abnormal situation in your patient that we are going to have to deal with, we're going to have to treat. Next, we have the chemoreceptors. We've talked about chemoreceptors in terms of other things in the body, like acid-base balance, etc. Those chemoreceptors, though, are going to cause vasoconstriction or vasodilation of the coronary vessels and of the vessels in the rest of the body in order to be able to accommodate for different kinds of conditions that are happening in the body. So CO2, O2, pH, those things are going to activate our chemoreceptors to cause vasoconstriction or vasodilation, and that's going to try to optimize our cardiac output. All of these autonomic controls are designed to try to optimize our cardiac output. None of them are put in place to try to make things more difficult. They're put in place to try to maintain homeostasis all of the time in our patient. Next, we have our baroreceptors for stretch. They respond to changes in blood pressure. We have baroreceptors in the aortic arch and in the carotid bodies, and when we have increases or decreases in blood pressure, they sense that and say, whoa, blood pressure is not what it's supposed to be. Let's fix this, and let's either raise the blood pressure or decrease the blood pressure. Okay, let's stop for a second and think about this. If the baroreceptors are responding to stretch and they're going to either increase or decrease the blood pressure, what are the baroreceptors stimulating? Okay, now if you said the sympathetic and parasympathetic nervous systems, you were correct. That's what the baroreceptors are going to be stimulating. So you see how these things all kind of fit together. All right, now as far as our cardiac function goes, first thing we're going to take a look at in our cardiac function is going to be the heart sounds. Now hopefully you've had a chance to get a stethoscope or to borrow a stethoscope from somebody and play around with the stethoscope a little bit, because what you want to do is to start listening now to heart sounds and start listening in different people. I know you haven't had this in the lab yet, but that's okay. You can still start listening to heart sounds and get a feel for what the heart sounds like. Now we're talking about an S1 and an S2 sound. This is the lub-dub you hear. So when you're listening to somebody's heart, what you're going to hear is lub-dub, 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 assuming that they've got normal cardiac function and that they don't have any kind of a heart murmur. We're going to hear lub-dub, lub-dub. Now what you're hearing, those two sounds are named S1 and S2. So S1 is the lub, S2 is the dub. So we've got lub, dub, S1, S2, and that's what you're hearing when you're listening to the person's heart sounds. So start listening to yourself and see if you can hear your heart sounds. If you already have your stethoscope, if not, see if you can borrow one from somebody and start listening to heart sounds so you can start hearing what a lub, dub, what the S1, S2 sounds like. A heart murmur is an additional sound, and it's caused by having turbulent blood flow through the valves. If the patient has a really bad, like heart failure, for example, they may end up having all four sounds. Okay, now we haven't defined those yet, but there's more than just S1, S2. Those are the normal ones, but the abnormal ones are S3 and S4. Okay, we're going to look at those in just a moment. A new murmur after a myocardial infarction. So MI is an abbreviation for myocardial infarction, and a myocardial infarction is when a patient has decreased perfusion to part of the heart and the heart muscle starts to die. But a new murmur after an MI could indicate a papillary rupture, those are the little muscles that are holding the valves, heart failure, or pulmonary edema, or maybe all of the above. So let's take a look at those heart sounds. Now, as I mentioned before, S1 and S2 are the normal heart sounds, and what I've done here is we just kind of coordinated them with what we would see on your EKG. So if you were looking at an EKG on your patient at the same time that you were listening to heart sounds, you'd see something like this. This is kind of what it would look like. But at any rate, we don't need to do that right now in order to be able to understand heart sounds. So we're looking at S1, S2. S1, S2, or S1 and S2 are the normal ones, lub dub, lub dub, lub dub. Let's talk about where those come from so that you have a better idea as to why you're hearing lub dub. S1 and S2. When the heart contracts, it starts at the atria. So the atria contract before the ventricles contract. This is actually kind of a good thing. If the atria and ventricles contracted at the same time, blood wouldn't go anywhere because it's just pressing against each other. So instead, the atria contract first, and they are going to squirt blood down into the ventricle. Then the ventricles contract and squirt blood out to the body or to the lungs. So this is a good system that we have one step at a time rather than having boom, both of them happening at the same time. So we're going to have the atria contract first, then the ventricles contract. When I listen to somebody's heart and I hear lub dub, in my mind I'm thinking, okay, that's the atria contracting and the ventricles contracting. But the atria and ventricles, when they contract, they don't make any noise. The noise occurs when the valves close. It's like the closing of a door. When somebody walks out the door, it doesn't make noise. But when the door slams behind them, it makes the noise. And that's what we're hearing when we listen to somebody's heart sounds. We're actually hearing the valves close. So the atria contract, and then the AV valves close, and we get S1. The ventricles contract, and the aortic and pulmonic valve close, and we get S2. So those are the normal sounds that we're hearing. All right, well, listed here, we've got additional sounds. Let's take a look at the first one, which is our S3. Now, an S3 sound is an abnormal sound. We shouldn't have it. We should just have the atria contract, AV valves close, ventricles contract, aortic and pulmonic valve close. We got our S1 or S2, boop, that we're done. But if the patient starts to have some dysfunction, we can end up having additional sounds, S3 being one of them. An S3 heart sound occurs because our patient has fluid volume overload, so there's too much fluid on board. Now think about the process of what's happening with the heart. Atria contract, AV valves close, and we get S1. Ventricles contract, the aortic and pulmonic valve close, and we have S2. So now, what's happening in the heart after the ventricles contract? The atria are filling. So now the atria are filling after S2. The atria are filling. And because the patient has fluid volume overload, they have too much fluid on board, too much fluid is rushing into the heart, it's going to make the valves flutter, and that causes an S3 sound. So because the fluid is rushing into the patient's heart, it's going to make the valves flutter, and we get an S3 sound. Now, in nursing school, they taught us about the terms Kentucky and Tennessee. The reason for using these terms is to help to understand the pattern by which we hear these sounds. So in terms of the S3, it's supposed to be Kentucky, Kentucky, Kentucky. You know, you got that S3 coming right after. Now, I never got these down right. So what works better for me is these terms that we're going to use here, sloshing in and a stiff wall. So let's take a look at S3 first with sloshing in. So the pattern is going to be lub-dub-da, 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 sloshing in, sloshing in. That's the pattern you hear with an S3 sound. Okay, now we're going to listen to an S3 sound, so listen carefully here. You might have to turn up the speakers a little bit. I amplified it a little bit, so hopefully you can hear it. But we're listening for the pattern. This is not a sound from an actual patient. It's a computer-generated sound so that you can pick up the pattern of what the sound would sound like. Okay, our next sound is going to be the S4. Again, S1, S2 are the normal ones. So we have the atria contracting, AV valves closing, we get S1. Ventricles contract, the aortic and pulmonic valve close, we get S2. Then what's happening? Okay, the atria fill, no problem, we don't have an S3, so the atria are filling. Then what happens right before S1? Remember, right before S1, what's happening is that the atria are contracting. So the atria are contracting and they're pushing blood out. They're contracting and pushing blood out, and that is causing the S4. So in an S4, what's happening is that the patient has a non-compliant ventricle. Maybe the patient's got something like they had a myocardial infarction. So they have a non-compliant ventricle because the ventricle's ischemic. And that's what's causing the patient to have this sound. The atria are pushing blood down into this non-compliant ventricle, and that's causing this vibration of the valve, and that's causing the S4. So an S4 is going to sound like to-lub-dub, 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 a stiff wall, a stiff wall, a stiff wall. That's the pattern that you're going to hear with an S4. Now let's listen to an S4. This one people often have trouble hearing. You have to kind of anticipate the sound because the sound comes right before S1. Also, keep in mind your S3s and S4s are going to be softer and lower pitched than the S1, S2. So hopefully you were able to hear that. All right, let's move on then. Cardiac output is the amount of blood that is ejected from the ventricle every minute. So what we have to do in order to determine how much blood is ejected from the heart in a minute is we have to look at the heart rate, because the more times per minute the heart beats, the more blood it's going to pump out. And we have to look at the volume of blood that was in the ventricle when the ventricle contracted. So we have to put those two things together. Now, here is the formula for cardiac output. Cardiac output is heart rate times stroke volume. More math, huh? All right, well, and that's what often gets people here as we say, oh boy, I'm not going to be able to understand this one because it's more math. All right, well, it's a really pretty easy concept. Again, the more times per minute the heart beats, the heart rate, the more output we get. The more volume that is in the blood with each contraction, the more volume we get. So hopefully that makes a little bit more sense to you. Just think about it in terms of that. How much volume the heart is pumping times how many times per minute the heart beats, that gives us our cardiac output. Normal is about 4 to 8 liters. And again, we're talking about per minute. So 4 to 8 liters a minute. Our cardiac index is another value we may look at, and that takes the cardiac output, so our 4 to 8 liters a minute, and we divide that by the patient's body surface area. Wouldn't it make sense that somebody who's larger would need a higher cardiac output than somebody who's smaller? And that's why we use the cardiac index. So the question at the bottom says, how do we know that somebody has an adequate cardiac output? Well, we're going to have to look for clues in the way that the patient's presenting. We're going to have to look for clues in whether or not organs are being perfused, whether or not their skin is being perfused. So we're going to have to be looking for clues in all of those areas to be able to tell us that somebody has an adequate cardiac output. Cardiac output and systemic vascular resistance are some additional components we're going to consider. So we did talk about cardiac output here at the top. Systemic vascular resistance is the resistance of the blood vessels. Now specifically here we're talking about the arteries. The veins don't put up a whole lot of resistance. Mostly their function is to get blood back to the heart. So that's not such a big deal. But the arteries are going to be a big deal. They're going to cause us a significant amount of resistance. Think about it like a hose. So you're going to go out and wash your car here in summertime, and it's nice and warm out, and you're going to get the hose out. So you get the hose out, and you're ready to wash the car, and you turn on the hose, and you go over and you start trying to spray your car down, and there's hardly any water trickling out of that hose at all. You go back and you look, and whoop, there it is. The hose is kinked. Now, the same thing's going to happen in the body. If the hose gets kinked, if the vasculature gets kinked, then we're not going to be able to have good perfusion to the rest of the body. In addition, what happens when you unkink that hose? Don't you get this big burst of water that comes down through because it was building up so much pressure behind that kink? And the same thing happens too with the heart. When we get a lot of resistance in the vasculature, it backs up to the heart and puts too much pressure on the heart. Arterial blood pressure is a function of both systemic vascular resistance and cardiac output. In fact, if you break up your blood pressure into two components, we have the top number, which is the systolic. And systolic is a component of cardiac output. The bottom number, the diastolic, is a component of your vascular resistance. Now, you're going to get more into that a little bit later on, so I'm just introducing it here. Don't get real worked up about it. You're going to hear it again. Pulmonary vascular resistance, on the other hand, comes from the pulmonary system. So this isn't something that is going to have a dramatic effect on your cardiac output in most people. However, if your patient has got some kind of pulmonary condition, some kind of chronic pulmonary condition like COPD or pulmonary fibrosis or anything like that, then you may end up having some problems with pulmonary vascular resistance. The primary things that are going to affect our cardiac output is going to be the components of cardiac output, we'll get to those in a moment, and our systemic vascular resistance. There we are, of course, components of cardiac output. In order to make cardiac output, we have to have fluid coming in and fluid going out. And if there's not enough fluid coming in, there won't be enough fluid to pump. So obviously, cardiac output will decrease if we don't have enough fluid coming in. In addition, though, we can also decrease our cardiac output if we have a kinked tube. So let's go back and let's take a look at that preload again. Preload and afterload, these are terms that are used when we're describing how much fluid is coming into the heart and how much resistance the heart has to pump against. And, these are just terms that, I don't know if they come from physics or where they come from, but these are terms we use to describe patients who have problems with their cardiac output. And when in relationship to our cardiac output, we use these terms. We can also think about it in terms of the heart being the pump, like an IV pump or any other kind of pump, and these other components coming before and after. So the preload then would be the load before the pump. Well, the load before the pump is going to be the fluid coming into the pump, right? So there's no other load coming into the pump other than the fluid. So preload is fluid volume, and it's always going to be fluid volume. It's going to be increased, as it shows here, if the patient has hypervolemia. In other words, if that patient has too much fluid on board, like they have heart failure, for example, or if they have some kind of renal problem where they can't get rid of fluid, there will be too much fluid on board, and too much fluid will enter into the heart, and we'll have an increase in our preload. Now, we can also have, it just says here on our picture, it just talks about increases. We can also have a decrease. What if your patient was dehydrated? Then there wouldn't be enough fluid coming to the pump to be able to run the pump. And the patient would have a decrease in preload, which then would result in a decrease in cardiac output. On the other side, we have the afterload. The afterload is the resistance that the heart has to pump against. The resistance our heart has to pump against is going to be the arterial vasculature. Okay, so that's pretty straightforward. We have the vasculature, just like the hose we talked about before, becoming kinked. If it becomes kinked, it's going to increase the resistance the heart has to pump against. It's like your hose out there, and you can't get any flow on the other end of your hose because the hose is kinked. And the other thing that happens, of course, is that fluid starts backing up. And you can see from the picture here, it looks like fluid is backing up into that left side of the heart, which is going to cause the patient to potentially have some problems with their cardiac output. Couple calculations here. These are things that you probably ought to just start getting used to looking at and kind of filing these away someplace. So maybe it's a matter of filing this away in some part of your brain so you can come back to and get to it later. So some important calculations that you'll have to keep in mind as you go through your nursing career would be these here. The pulse pressure is the first one. Pulse pressure is the systolic pressure minus the diastolic pressure. So if you were to take what would be a normal blood pressure of 120 over 80, the systolic would be the 120 minus the diastolic of 80. That means our pulse pressure is 40. There are situations that occur in your patient where pulse pressures can be abnormal, and that's why we're going to be checking our pulse pressure in patients to find out what the pressure is for that particular patient. So that's something we can be looking at, and we're going to talk more about this as you get into some of your more advanced classes. Mean arterial pressure is another value, and this is one that you're going to see right away in your very first clinical, the first time you take vital signs on a patient using one of the automated systems. Our automated blood pressure cuff machines read mean arterial blood pressure, so we do need to have an idea as to what that means. The mean arterial pressure is the mean pressure. You could think of it as, and I hate to mess up the different terminologies here, but think about it as being the average amount of pressure that's in the vasculature. I mean, it's not quite the same, but think about it as being the average amount of blood pressure that's in the vasculature. So what we take is we take the systolic blood pressure and then we add to it the diastolic blood pressure times 2. The reason why the diastolic gets twice the weighting in this equation is because diastolic time is longer than systolic time. So think about your heart right now. Your heart beats and then it rests. It beats and then it has a period resting. The resting period is twice as long as the beating period. Therefore, we're going to give the resting period, the diastolic, twice the weight in the equation. So we take the diastolic pressure times 2 plus the systolic and divide the whole thing by 3. A normal mean arterial pressure is greater than 60, and this all depends upon your patient population. Just kind of store that number away in the back of your head, that we want to have a mean arterial pressure of 60 in our patient. In some situations, we may want that pressure to be higher. Other situations, we may want it to be lower, but just kind of think of that now as kind of hang on to that as being kind of what the normal should be. So as we look at some of the different areas of the myocardium, first of all, we need to talk about the endothelium. The endothelium, remember, is the inside lining. The inside lining of your organs is the endothelium. In this case here, the endothelium is going to be both around or on the inside of the heart and the inside of the blood vessels. On the inside of the blood vessels, the endothelium is going to be very important because this is the area that can become inflamed, and this is the area that can start to produce atherosclerotic disease. Vascular resistance is another one of our components that's going to affect our cardiac output, and it can be affected by a variety of different factors, including the amount of pressure that's in the vessel to begin with, the amount of resistance we have, that'll affect our blood flow, and the resistance is going to be caused by vasodilation or vasoconstriction. Now, there's two other concepts here that we need to think about a little bit. One is laminar flow, and the other is turbulent flow. Laminar flow is normal flow through a vessel, through a tube, would be normal flow. Turbulent flow occurs when we have some kind of partial obstruction to that vessel, and it starts making the blood move in a turbulent manner rather than just nice and neatly down the river. So think about it like this. You've got a river, and the boat's floating down the river. A nice little sailboat floating down the river. The river is just moving right along. There's no ripples. There's no waves. The current is just moving nice and neatly down that river. That would be similar to what laminar flow would be like. Nice and smooth. Things are moving nicely along there, etc. Okay, how about if we have a whole bunch of rocks in that river? Now, as the flow is going down, we're going to get a lot of turbulence, a lot of turbulent flow. We're going to see a lot of waves and a lot of white water and things like that. That's the turbulent thing. And we don't want to have turbulence inside the vessels because turbulence is going to stimulate clotting. Clotting then in turn is going to stimulate your patient to develop atherosclerotic disease and maybe even thromboses or emboli that can cause the patient to have an MI or to have a peripheral venous thrombus. Blood pressure is the outward measurement of all of these components put together. So we're going to put all these components together in the vessel, and then we're going to measure that by looking at our blood pressure. The more flow we have, the more resistance we have. That's what's talked about here in the bottom. So here is a picture showing our laminar and our turbulent flow. The top picture is showing a laminar flow, and one of the things it's illustrating here is in the center of that vessel, we have the greatest amount of flow. We're going to have less flow around the sides because now the blood is touching the vessel wall, and that's causing a little resistance and slowing it down just a bit. Not a lot, not horrible, but just a little bit. Okay, now let's take a look at the bottom picture. And in the bottom picture, we have some constriction of that vessel. Notice that now the blood starts going in all sorts of crazy ways. It's kind of circling around and things like that. So now we have that turbulent flow. Problem with turbulent flow is it's going to start activating platelets and start causing clots. Atherosclerotic disease is a chronic disease in the arterial system that can cause a patient eventually to develop thrombi, to develop clots in the vessels, which could cause some kind of damage to organs. And the ones we're mostly concerned about is going to be the brain and the heart. But we get an abnormal thickening and hardening of the vessel that occurs. We think what causes atherosclerotic disease to occur is that sometime earlier in our lifetime, we encounter some kind of infection, and that scars the vessel just a little bit, just a teeny little, not a big deal. You don't have any symptoms at the time, but it's a little bit of scarring on the vessel. And then the vessel will start to cause an inflammatory process. As part of that inflammatory process, we get platelets to the area and fibrin and things like that, and it starts to form this little plaque. Now, this plaque is going to then cause a little bit of turbulence in the area, which is going to cause more clotting and more things to start to stick there over time. This is not something that happens overnight. This is something that happens over a period of many, many years. And there are things that are going to contribute to this and possibly make it more likely that your patient will develop atherosclerosis. So it's an abnormal thickening and hardening of the vessels. We get these deposits inside the lumen of the vessel that are mostly, they call it a fatty streak. But this little fatty streak starts there, and it starts collecting other things on it, like fibrin, like platelets, etc. And then it starts to become harder. And as it becomes harder, it's going to cause more turbulence and possibly cause a clot. The other thing that could happen, too, is that the plaque could break off. So it's a hard little plaque sitting there in the vessel, and one day it just cracks and breaks off. Well, that thing's going to go downstream, and it's going to stop a smaller vessel downstream, which could cause then some kind of damage to the heart, to the brain, or to some other organ system where that little plaque went to. So this picture here is showing some of the injury that can occur and how this is going to affect the patient. So at the bottom of the page, we're seeing the normal artery here, and we see the different layers of the artery. And then on the right-hand side, we're seeing the disease, the occluded artery, and in this case here, we've built up quite a bit of the inside layer of the vessel in order to occlude that artery. So that's going to start to cause this fatty streak or this fibrous plaque, which starts to limit the inside size of the vessel, decrease the blood flow through that vessel, and then we're probably going to see some symptoms in our patient. Diseases of the veins. Now keep in mind that the veins are going to be a low pressure system in the body. They're a low pressure system and they are thin walled, and what the veins are doing is bringing the blood back to the heart. So we have the arteries taking the blood to the tissues of the body, the veins bringing it back. The primary function of the brains is just to get the blood back to the heart. So it's a low pressure system. We don't need a lot of pressure in there to do that. They're thinner walled than arteries. Arteries have a much thicker muscular layer to them than veins do. Veins do have some muscle to them, and that's why if you ever go to the doctor's office and they want to draw blood from you and your veins just kind of disappear, okay, well they kind of constrict it on down there. You scared them, and they kind of constrict it on down there, and then you can't see them. So they do have a muscular layer to them. It's just not as big as the muscular layer in the arteries. Also, valves have something the arteries don't have, and that's veins have something that arteries don't have, and that's valves. Valves will help to prevent a retrograde flow. So we don't want that flow to go backwards. We want the flow to go toward the heart. So in which case we need to have valves in there to make sure that the flow is moving toward the heart and not backwards. Skeletal muscles will help to compress those veins and help to move blood back up to the heart. So it's really important your patient's getting up and ambulating and moving around so that we're getting compression of those muscles, and that's compressing those veins and moving blood back up toward the heart. This terminology here, deep vein thrombosis, now you're going to see this terminology kind of thrown around with another one, which is venous thromboembolism. And I think in most cases now we have changed our terminology and we're talking about these things as being a venous thromboembolism rather than being a deep vein thrombosis. At any rate, what's happening with either a DVT or a VTE, however you want to describe it, is that we are going to get a clot in one of those veins, and that's going to block the flow backwards, and the patient's going to get swelling, etc., of the limb. Varicose veins, which we saw in our previous diagram, let's go back and take a look at that again. See those veins that are really sticking out? There's an arrow there pointing to them, and the veins are sticking out and they're all distended and tortuous. And these are veins that have fluid backed up in them. So the valves haven't worked very well. Blood is starting to back up, and it's making the valves, or it's making the veins rather, distend. That's called a varicose vein. The problem with varicose veins are twofold. One is that we have too much blood that is sitting back there and pooling, which could cause clotting. Okay, so that could be a problem. Secondly is that because these veins are pooling blood and they're hyperdistended, we're stretching that muscular layer a little bit too far, and that can lead to the patient developing fragility to that vessel, which then it could pop and it could bleed and cause problems. Another common problem that we see with the veins is chronic venous insufficiency. So this is a situation where we have inadequate venous return over a long period of time, and they're probably due in most cases to varicose veins, but can also be because we just have valvular incompetence and we're not getting that blood back up to the heart. So the venous blood is kind of sitting there in that extremity, and then this can cause the patient to develop venous stasis ulcers. Remember, blood has to be continuously moving through the vascular system. It has to go through the artery, through the capillary, and through the vein and back to the heart. It's got to be continuously moving for this to work. Think of this as like stagnant water. So you've got a stream going through the back of your yard and something blocks it up and becomes stagnant, and that stagnant water is going to start to stink, okay? It's going to start to have problems, etc., because it's not moving. A nice moving stream stays nice and clean, but when it becomes stagnant, then it starts to have some problems. And the same thing's going to happen here. The blood becomes stagnant, it's starting to back up, and we're not getting rid of those waste products and getting them away from the tissue, and so therefore it's going to start to cause some dysfunction of the tissue, which will lead to a stasis ulcer, in other words, damage to the tissue and an ulceration. Hypertension is a situation where we have an increase in our systemic arterial blood pressure. In most cases, most hypertension is going to be caused by some kind of renal deficit. The kidneys are kicking in and they're starting to cause the patient to have more renin on board, which is causing some vasoconstriction or things like that. So we have a sustained increase in our peripheral arterial resistance from arterial vasoconstriction. This can cause some serious problems in your patient. One is that we're going to start to get some chronic damage to the vasculature. Probably more importantly is the heart has to try to beat against this. The heart has to try to push blood past these hypertensive vessels. Again, think about the hose. We have the garden hose out there, and you're going to wash your car, and somebody kinked the hose. All right, so we're going to build up pressure. Pressure is going to build up behind it. Now you unkink the hose and whoosh, you get this sudden whoosh of water that's coming down the hose. And the same kind of thing, it wouldn't really happen in the body because we're not unkinking, but we're getting that back pressure. And that back pressure is going to go back to the heart. And it's going to put too much pressure on the heart, and it's going to cause left ventricular hypertrophy. That's LVH. Okay, and just tossing it out there. Another term for left ventricular hypertrophy, for LVH, another term for that is cardiac remodeling. Just kind of tuck that away somewhere in the back of your mind, just so that you can kind of revisit it at some point in time, okay? We're not going to get into a lot of detail with that right now. Angina. Angina is chest pain that's caused by an inadequate amount of oxygen getting to the myocardium. So we're stressing the heart. Now the patient's starting to have some chest pain in relationship to not getting enough oxygen to the heart. Heart failure. And this abbreviation you see here, CHF, stands for congestive heart failure. What you're going to find is that we're changing the terminology a little bit on this, and rather than calling it congestive, because very few people actually have the congestion part, we call it heart failure. So you're going to see these terms interchangeably. You might see it written CHF, you might see it written just simply as HF, meaning heart failure. When you get into your clinical areas, you might see, in addition, CHF meaning chronic heart failure, and AHF meaning acute heart failure. So just so that you're aware if you start seeing these different terms as you move along. Myocardial infarction, that's an MI. Myocardial infarction is damage to the myocardium because of a lack of blood flow to an area of the heart. Aneurysms can occur in the vasculature. So an aneurysm is an outpouching of the vessel. Strokes can occur in the brain. Thromboses, we can get blood clots. So all sorts of complications can result because of hypertension. Hypertension is abbreviated as HTN. You might see this abbreviated in somebody's chart as being simply HTN. So that stands for hypertension. There's basically two different types of hypertension. The first type is called primary. Primary is also called essential hypertension. So you may see it written in the patient's chart that the patient has essential hypertension. That's primary hypertension. Almost all of our hypertension is primary in nature. No particular thing that's causing it. There's a number of things we think may be contributing. We may think the sympathetic nervous system. RAA is the renin-angiotensin system. Okay, so it's actually renin, angiotensin, and aldosterone. Insulin resistance, inflammation, lots of things we think may be a contributing factor, but most of our hypertension, we really don't know what it is that's causing the patient to have hypertension. So we're going to treat it kind of symptomatically. We're going to give the patient medications that keep the blood pressure down and just watch for other conditions to occur in the patient's body. We may have a secondary hypertension as well. This is caused by some specific problem that we can put our finger on and say, okay, it's because the patient has renal failure. It's because the patient has adrenal tumor. So secondary hypertension is one in which we have a actual diagnosis that we can link it to. In some cases, that might make it easier to treat. In other cases, it doesn't, like adrenal tumors. Well, unless we're going to take out that adrenal tumor, it doesn't make it a whole lot easier to treat than if it was just primary. So this picture here is just giving you some idea of where some of these things plug in to cause hypertension in our patients. So starting at the top of the page, we have the genetics and the environment. So, and one of the pieces in our environment that causes people to have hypertension is a high caffeine intake. So, that's part of your environment there. So we got a little bit of a genetic predisposition. We add some caffeine to that and maybe something else like cigarette smoking or whatever. And now we're going to have some dysfunction in our sympathetic nervous system. Remember again, RAA is renin, angiotensin, aldosterone system. We're going to start seeing some problems with our natriuretic hormones and etc. And those things are going to cause vasoconstriction. Over on the left-hand side, we also get insulin resistance as a result here, or as a possible result in this process. And on the right-hand side, some inflammation. Those things don't cause hypertension, but they do contribute to the process. So on the left-hand side, the insulin resistance will also help our sympathetic nervous system, the renin, angiotensin, aldosterone system, in causing vasoconstriction. On the right-hand side, our renin-angiotensin aldosterone system and our sympathetic nervous system, along with inflammation, will cause renal salt and water retention. Those things increase our blood volume, whereas on the left-hand side, the vasoconstriction increases our peripheral resistance. So put that all together, and what do we get? We get sustained hypertension. So we have an increase in total volume, we have an increase in our vascular resistance. Okay, now if you were to treat this, now let's assume that the genetics, environment, whatever, there's nothing there to treat. The patient has a genetic predisposition to hypertension. You can take the things out of the environment. Take the caffeine out of the environment, take the cigarette smoking out of the environment. Okay, we can take those things out, but we're still stuck with the situation here where the patient has already got this dysfunction going on. Let's go down to the bottom of the page here, and the bottom of the diagram, and take a look at what we may be able to treat. What we may be able to treat is the increased peripheral resistance. So we give the patient a medication that causes vasodilation. Over on the right-hand side, increased blood volume, we give the patient a medication that allows them to decrease their total fluid volume, such as a diuretic. A diuretic helps the patient to be able to lose, to release some extra fluid that's on board. So those are some of the things that we can do to treat a patient who has hypertension. We can't necessarily go all the way back to the source and change the genetics. We can change the environment, and that's one of the first things they do. If somebody comes in and they've got a high blood pressure reading, the very first thing your doctor's going to do is say, okay, change your diet, get exercise, stop drinking coffee. They're going to eliminate those things that they can. If the patient's still hypertensive at that point, then we've manipulated everything we can at the top of the screen. We've got to move down to the bottom of the screen to use medications to help to treat it, because we don't want the patient to have that hypertension, because hypertension has consequences associated with it. Malignant hypertension is a situation where the patient has a rapidly progressing hypertension with a diastolic pressure generally above 120. Okay, so you might want to correct this when we consider it to be malignant or we consider it to be an urgent type of a hypertension. The diastolic pressure generally is going to be considered to be above 120 millimeters of mercury. The problem with having a blood pressure that high is there's too much pressure. There's too much pressure in the vasculature, and it's going to cause vessels to burst. It can also cause the patient to have significant problems with cerebral edema, etc., because of hydrostatic pressures pushing fluid out into the brain. Orthostatic hypotension, on the other hand, is a situation where the patient has a low blood pressure, and this will be evidenced by the patient standing or sitting. Now, if you've ever known anybody who maybe became dehydrated, for example, and they stood up and passed out, or somebody who went and they gave blood and they stood up and passed out, that's a very good clinical example of what orthostatic hypotension does. If you were to stand up quickly, the blood pressure drops. Why? Well, the reason why the blood pressure is going to drop when somebody stands or sits, and by the way, this happens to everybody all the time. The reason why your blood pressure drops is because blood suddenly, by gravity, gets pulled down into the lower extremities. Now, in most cases, you have an intact system, and this is specifically the sympathetic nervous system, that's going to kick in, and it's going to recognize this. Remember those baroreceptors? They recognize this immediately, and they send out signals to cause vasoconstriction so that you maintain your volume in the upper part of your body. But what if you didn't have enough volume on board? Then while you're laying down, you may feel fine. But as soon as you go to stand up or sit up, then blood starts rushing down on the lower extremities, and yes, you have those compensatory mechanisms, but they're not enough. It's not enough because your volume is low, and that's why you end up passing out. Now, we are going to test orthostatic hypotension in our patients by taking a blood pressure with them laying down, with them sitting up, and with them standing up. So some of the factors that regulate the blood volume in our patient are going to be the amount of blood in the vessels, the blood volume in the vessels, ADH. Remember, ADH is going to help the patient to be able to retain water. The sympathetic nervous system, and that's going to be by the function of the catecholamines, constricting our blood vessels, and in the renin-angiotensin-aldosterone system. You're going to see this abbreviated in a number of different ways. Previously, we saw it abbreviated as RAA. In this case here, they're abbreviating it as RAAS. So this is the renin-angiotensin-aldosterone system. This system is activated by the kidneys. So the kidneys kick in, and they're going to activate this system. Now, the kidneys are kind of selfish here. They don't really care what the blood pressure is in the rest of the body. They're trying to maintain the blood pressure inside the kidney. So the kidney senses that there's a decrease in blood pressure and says, hey, we need more blood pressure down here, and it stimulates renin release. Renin then gets converted to angiotensin, and then angiotensin is going to stimulate the vasculature in order to cause vasoconstriction. So this process is being stimulated by the kidney because the kidney wants more pressure. It doesn't mean we need more pressure. It's just the kidney wants more pressure, and so that's how this system starts, and that's how the system begins. Aldosterone is also part of this system. It's intertwined in the system. Now remember, aldosterone tells the kidneys to hang on to fluid. So the kidneys are recognizing they think there's not enough blood volume on board. They think the blood pressure is low because there's not enough blood volume on board, when in fact the blood pressure to the kidney could be low because we have a constriction or an obstruction of the vessel going to the kidney. So in which case, stimulating this renin-angiotensin-aldosterone system would be dysfunctional. Other factors that affect blood pressure include our natriuretic peptides. The most common one here that we talk about is called BNP. BNP stands for brain natriuretic peptide. Okay, now this may be a little confusing for you, right? You read this, it says brain natriuretic peptide, a marker for cardiac disease. How can brain natriuretic peptide be a marker for cardiac disease? Well, the fact is that brain natriuretic peptide, BNP, actually comes from the heart. So these natriuretic peptides are coming from the heart. There's a BNP, there's an ANP, there's a CNP, and we think there may even be a D or EMP. So those are just additional ones out there, but the one we're mostly concerned about, that we're looking at the most, is our BNP. The reason why it's called brain natriuretic peptide is because originally, how it was first found, was it was cultured in the brains of animals. So that's where the B part, the brain part, comes from. They have the opposite effect of ADH in the renin-angiotensin-aldosterone system. Instead of having the patient hang on to fluid and increase blood pressure, natriuretic peptides will cause the patient to get rid of fluid and vasodilate, which is a good thing if we have too much fluid on board. These are a backup system, so we shouldn't need these. The kidneys should respond when we have too much fluid on board and get rid of it, but if they don't, we have this backup system of the natriuretic peptides, which is going to help us to be able to maintain our fluid volume and keep it away from the heart. Baroreceptors, we've talked about those. We have stretch receptors in the aorta and the carotids, and those are going to help us to regulate our blood volume and our blood pressure. Insulin resistance has a role in vascular injury. There's a number of things that can lead to insulin resistance. Even diet can have a dramatic effect on insulin resistance. Resistance to insulin causes endothelial injury. Remember, the endothelium is the inside lining of the blood vessel, and this can be the beginning of the pathogenesis of hypertension and/or atherosclerotic disease. Neural control of our cardiovascular system. One of the things it's going to do is it's going to cause a change in the diameter of the arterioles. The arterioles are going to primarily affect how much blood is going to go down through the capillary network. It's a reflex control of cardiac output and resistance. We have our sympathetic stimulation, which is going to stimulate things. Sympathetic stimulation makes everything. This is the fight or flight response. So you get the tachycardia, the hypertension, etc. Parasympathetic does just the opposite. So if you can remember one of them, then just flip it for the other. So if the sympathetic system makes the patient hypertensive and tachycardic, the parasympathetic system makes the patient hypotensive and bradycardic. The bottom line, the brain regulates vasoconstriction of vessels in order to be able to maintain our blood pressure. Okay, now you might want to add to that not just the brain, but we also have those baroreceptors that can function independently of what the brain is doing. An aneurysm is an outpouching of a vessel. This is an abnormal thing, and what happens is that the inside lining of the blood vessel kind of pops through an area, a weak area in the muscle. It's like a hernia. So anybody who's had a hernia, or known somebody who's had a hernia is an outpouching where the inside of the abdomen, some part of the inside of the abdomen, could just be the fascia, pops out through the muscle layer because of a weak area in the muscle. Same thing is happening here with an aneurysm. We have the inside lining of the blood vessel popping out through the outside lining of the blood vessel because we have an area of weakness in the muscle. Some things can contribute to this, like atherosclerotic disease, inflammation, hypertension. Certainly, the more pressure there is on the vessel, the more likely it is that an aneurysm could form. This picture is showing some aneurysms. What we're seeing here over on the right-hand side is the heart up at the top, and you see the aorta coming down and the two kidneys. And that big, huge, wide thing right up there by the heart is a descending, this is actually a dissecting aortic aneurysm. So a big, enormous aneurysm. Now that is, okay, just so you're looking at it and thinking, oh my gosh, that thing looks, bigger than the heart. That thing is split open so we can see the inside of it. Over on the left-hand side, let's take a look at some of these different aneurysms. Over on the left at the top, we have aneurysm that is formed on both sides of the vessel. So this would be a situation maybe where we have some kind of damage to the vessel wall. Maybe it's happening at a bifurcation or a connection or something like that, where both sides of the vessel wall could be affected at the same time. Over on the right at the top, we have the fusiform saccular, and what that is just one side that's bulging out. Now you can see all three layers of the vessel are involved here. So we have a muscular weakness, and all three layers just kind of bulge out with that muscular weakness. So the muscle's weak and the muscle's bulging too. Down on the bottom on the left, we're seeing a false aneurysm. Now, a false aneurysm means that we've got like a hole going through the muscle and we've got a clot on the outside. So it's not really an aneurysm. It looks like an aneurysm because we've got this clot on the outside of the vessel that makes it look like the outside of the vessel wall is distended. Over on the right-hand side, we have what's called a dissecting aneurysm. And in a dissecting aneurysm, the different layers of the vessel start to pull away from each other. So what they're showing here is we have a hole in the inside layer of the vessel, in the endothelium, which is allowing blood to leak between the layers and form this big outpouching. What it's not showing you there in the picture is it goes both ways. It doesn't just outpouch, but it also pushes the inside layer in. And eventually it's going to push the inside layer in enough that there's no blood flow past it. Peripheral vascular disease is another of our cardiovascular disorders, and this is a situation where we don't have enough arterial blood flow getting to our patient. So one of them here we have is Berger's disease. This is a situation where we're going to have decreased blood flow, and that can cause the patient to have some pain, discomfort, and that's what we primarily see with our arterial peripheral vascular disease. Raynaud phenomena and disease is a situation where we get episodic vasospasm. So the patient has some episodes where they have vasospasm occurring in the arteries and arterioles, primarily of the digits, so it's primarily of the hand. And this can be stimulated by a number of different things, but one of the main things that predisposes somebody to Raynaud's phenomena is going to be collagen vascular disease like sclerodoma or smoking. Smoking can also predispose somebody to developing a peripheral vascular disease. Thromboembolism, and I kind of mentioned this briefly before when we talked about the possibility of a DVT, which is a deep vein thrombosis, versus the other terminology, which could be thromboembolism, a venous thromboembolism. So let's just talk about this and talk about thrombi and emboli for a moment. So first of all, we have a thrombus. A thrombus is a clot that is forming in a vessel, usually because we have some kind of damage to the inside lining of the blood vessel. So we have damage occurring to the blood vessel, and a thrombus, a blood clot, is forming inside that blood vessel. That is a thrombus. A thrombus is not moving, it's just a clot, it's sitting there. An embolism is a thrombus that's moving. Okay, so an embolism is a blood clot that is moving through the bloodstream and probably is going to get stuck somewhere. Eventually it's going to hit a small vessel and get stuck there. A thromboembolism is a blood clot that has dislodged and is moving through the body. So when we talk about an embolism, we're talking about something that has mobilized through the bloodstream. A thromboembolism, we're talking about a blood clot that is mobilized. And so very much so, a thromboembolism and an embolism are very much the same thing. It's just thromboembolism is very specific to it being blood versus an embolism could be some other kind of matter in the body.